Hello, everyone. My name is Corey Suraci, and I'm a fourth-year medical student at Geisinger Commonwealth School of Medicine in Scranton, Pennsylvania. And I'm here today with Dr. Douglas Beall, who is the Chief of Radiology Services at Clinical Radiology, and he's the Fellowship Program Director for the Musculoskeletal Radiology and the Interventional Spine programs at Clinical Radiology. Dr. Beall is also the founder of the Spine Fracture Institute in Edmond, Oklahoma. Dr. Beall, thank you for being here today, and it's an honor to speak with you again. The purpose of
Thanks,
today's
Corey.
Thank you. Purpose of today's video too is to show the outpatient side and for IR for medical students and undergraduate students pursuing this field. It will be the 14th installment in the Day in the Life series for the Society of Interventional Radiology's educational YouTube series. So Dr. Beall, why don't we start off with a little bit of background about yourself?
Yeah, sure. I'm an interventional radiologist. I practice in Oklahoma City, and I primarily do musculoskeletal intervention. And what that is kind of a combination of anything you could do percutaneous with the spine. Some of the things even not percutaneous. We do all invasive, minimally invasive treatments of the spine and joints. We do anything from injections to interspinous spacers for stenosis. We do minimally invasive lumbar decompressions. We do intrathecal pain pumps, neuromodulation, peripheral nerve stimulation. We do SI joint fusion. We do vertebral augmentation of all varieties, and a whole spectrum. The way this is that interventional radiologists kind of define themselves into various different sections. So you have, of course, neuroradiology, interventional neuroradiology, and then amongst interventional radiology, we primarily have things like interventional oncology, interventional musculoskeletal, and also peripheral arterial disease or venous disease. And so you can kind of sub-segment yourself into one of these subspecialties, and it probably be technically a subspecialty because IR is a subspecialty of radiology. So what we do primarily is interventional spine, interventional pain procedures, and this involves essentially a surgical subspecialty. So we see our own patients, have our own patient panel. We see primary consults. I get referred patients from everywhere. I started off as a referral-only practice, as was kind of a typical IR practice. And most interventionalists are used to being hospital employees. They're in a hospital. And I've not done that ever, really. I've had my own practice. I take referrals every single source. We take referrals from every single place, and we have a patient panel. We have patients who we follow along, some of which are, the majority of which are see and treat. So it's a diagnosis and treatment, and that's one of the special things about being a subspecialty of radiology varieties. You're able to diagnose and treat the patient, and the better the diagnosis, the better the treatment, is my hypothesis. And so the more accurate the diagnosis, the more accurate the treatment. So this is what we try to do. We try to, in effect, have a see and treat machine. And most of our patients are seen, hopefully promptly and correctly diagnosed, and treated in a minimally invasive way. And we start off at the top, and we click down using a combination of the least invasive things, graduating to the next step that's typically more invasive, but also typically more definitive. And we go down that list, and we stop at the combination of the least invasive thing that helps the patient durably. And this is, not a new concept. This was referred to as the inverse pyramid of stomatos. And this is kind of how our whole algorithm goes in treating patients. And then we follow them along, and this is, in effect, we are a surgical subspecialty that sees and treats patients, and always has a consistent, steady stream of new patients coming in, and hopefully treating as many of those definitively as possible.
Oh, awesome. Thank you for that too. And it sounds like the possibilities are endless. And clearly there's tons and tons of benefits for going private and being outpatient, like you're saying. So what are some current challenges, though, or some things you faced going into this practice model?
Well, one of the things you mentioned about the private practice aspect of it, and I've been in private practice for 17 years, been very happy with that. I started out in academic practice. In fact, I started out in military practice in an academic center at Lackland Air Force Base, Wilford Hall. And I was, very much like academic type practice, academic medicine. And we have anywhere between 5 to 8 ongoing clinical research projects. Always, I think we're about ready to start our 60th research trial. We publish between 1 to 3 level 1 papers a year. We publish up to between 5 to 12 manuscripts annually. I've written multiple books, and it's very much of a private-demic practice. And I think the industry and people who sponsor research and pay for product research and development really like private practice, because they see what is in effect somebody that has complete control with very little political overtones. And sometimes, as you know, even the institutional review board comes a political battleground. But in private practice, it's the main focus is on doing. The main focus is on accomplishing, and doing so without the paralysis by analysis approach. And we try to do things as quickly, expeditiously, and as inexpensively as possible. And so it tends to attract a lot of research sponsors who really want to try to collaborate with the experts in their field to perfect their medical devices, their drug device combos, and to do so quickly and with great alacrity. So this is one of the big benefits that we have out of it. I think, to segue into your next question, one of the greatest challenges is just inertia and tradition. Probably what I see around with my colleagues, and I've been in this space for quite some time, and have had the ability to get into different hospital systems, get onto the credentialing panels of other facilities, and have the ability to have a wide range of practice in terms of an office-based practice, an office-based lab, which is called an OBL, outpatient ambulatory surgery centers, and then HOPDs, and also have a fairly substantial inpatient population. So we had all sites of service, and that's purposeful. But one of the greatest challenges is, I think, when you're in a overlapping situation, like I do what most people would term as interventional pain, interventional spine, minimally spine procedures. And sometimes that territory is comprised of a number of different specialties. Sometimes that territory has, let's say, anesthesiology as a background. And so you could be caught in a scenario, because we're not really through that evolutionary period. You could be caught in a scenario where, let's say, an interventional neuroradiologist, you can put your catheter in somebody's brain, aspirate their clot, and save somebody's life from a stroke, but you can't be credentialed and privileged to do an epidural injection of the lumbar spine. We do more with scope of practice. And so I think that's, as radiologists arise out of the mud and slowly start to walk erect, and then propagate themselves from where they are currently or historically as a hospital worker only, and just being in the hospital, taking care of the hospital procedures, to being parts of other facilities, having their participating as a medical staff in other hospitals, to be able to have appropriate credentialing in the areas that they need to, and having the scope of practice battles that they need to win to be able to do what's necessary. And even though the hospital has an expert, minimally invasive surgical person of expertise, high expertise, that doesn't necessarily mean that the tradition of keeping that specialty out will some of the greatest challenges. And these are essentially growing pains, and expect to see these go away as the specialty and the amalgam of people who do this evolves.
Awesome. No, thank you for that. And I mean, certainly seems like there's no reason not to go into private. That's definitely hoping what I want to go into, especially after visiting with you today and seeing your practice. It was amazing, and definitely see the benefits and the positive
Give you
aspects of it.
more independence and autonomy. Yeah, it gives more independence and autonomy, allows for self-determination, and it's good. The downsides of it is it's all your responsibility. I mean, it's the pluses and minuses are more autonomy. You have to be very confident in your ability to and your motivation to accomplish what you want to. But if you are, there's very few barriers, and it's a very freeing type of practice. You can practice as much excellence as you can possibly muster.
Awesome. Oh, thank you. And yeah, in terms of going into the private side of practice as well, are there any future horizons or developments for interventional radiology? Because I know there's a couple groups across the country that are national for diagnostic radiology that are more on like the private side. But do you think interventional radiology will basically just stay, you got your own setup, your own OBL, or do you think there'll be more collaboration amongst a couple IR groups, or let's say a couple partners and whatnot?
What I really think will happen is the continued evolution of IR as a subspecialty, an independent, autonomous subspecialty. And with that, we'll have to learn how to graduate from fellowship and start a practice, what it takes, the place where you go and perform your business. It might be an OBL, it could be an ASC, it could be an HOPD, or it could be a combination. And I think the tradition of having IRs and DRs together is a good tradition. I mean, that's one that I'm steeped in. Yeah. But unfortunately, I didn't think it will work. The problem is these are different methods and modes of practice. You take a private practice group of, say, 20 people with 4 interventionalists, and the tried and true honored tradition is you get outvoted 16-4 every single time you want to do something. And that's not because some people look at it and some people look at it incorrectly. And so I think now we've seen that with the splitting of interventional radiology to its own residency. We have combination residencies, and this is probably will continue. Back when I was a resident, we had radiation oncologists as part of us, and now it's because so far afield you can't even hardly remember. The institutional memory that we were once trained together is gone completely, and they're separate. And that's very likely what will happen with IR. And as we kind of move forward in that vein, we find that we have far more in common with each other than we do with any other specialty. I had dinner last night with an interventional radiologist who does mainly angioplasty and stent placement, peripheral artery disease, embolizations, things like this. And I haven't done that in 10 years or more. I just focus on musculoskeletal orthopedic type stuff, and I found that I had more really understood his types. And so I think to be able to group together to find a little bit of power in numbers. I mean, radiologists tend to be a little bit more like wolves, and surgeons tend to be a little bit more like bears. And there's, to be independent, autonomous, and powerful is nice, but also to be fairly powerful and work collaboratively in a group also has the benefits. And I hope what we do is we evolve into a bear pack to combine both of the attributes that are best of both worlds into one. And I think that's really what will be necessary, and we'll be able to draw some of the IRs together and be able to establish independent and powerful practices that can do whatever you want, and whatever subspecialty that you have, whatever research you want to do. We'll be able to actually drill down and avail the practitioners of this, and the economies of scale and collaboration that allows will be very optimal.
Oh, yeah, no, thank you. And I was going to say, hopefully I'll be a future member of that bear pack in about 7 to 8 years or so. We'll see.
Yeah, I'm sure you will. Just keep charging forward and blink of an eye.
Yep. Goes faster every year, fortunately. Well, thank you so much again for this, Dr. Beall. It was great hearing you talk, and I'm sure this will definitely impact medical students and undergraduate students in future positions in interventional radiology.
Well, thank you very much, Corey. It's great to be with you. Enjoyed having you out. and let me know if there's anything I could ever help you with.
Yeah, no problem. Thank you.
You bet.